Welcome back to RadOnCAC's Smart Review GU Cancer series.
Glad to be here.
So, imagine your patient presents with a 5-centimeter fixed inguinal mass.
Okay, wow.
Yeah. And if your first instinct is to send him straight to the operating room, well, you just failed your boards.
Oh, absolutely. That's a major trap.
Exactly. Welcome to the high-stakes world of rare distal GU cancers. Today we are focusing on mock oral boards covering penile and urethral cancer, specifically node-positive and preservation cases.
Which, are incredibly high yield for the exam.
They really are. This session is designed to test your staging precision, your nodal logic, and your radiation design for diseases you might honestly only see a handful of times in your entire residency.
Right, which makes them perfect for oral boards.
Exactly. Because these diseases are uncommon, they make for excellent, highly discriminating board material. I am not looking for memorized trivia today.
Makes sense.
I am looking to see if you are a safe, logical oncologist who respects anatomy, histology, and the critical nuances of treatment sequencing.
Understood. I am ready.
Good. I will present 2 main case blocks, and each block will unfold in stages.
Okay.
For you listening at home, I instruct you to pause the audio after each question I ask. Formulate your own structured answer out loud, defend it in your head, and then listen to the model response.
It's the best way to practice, really.
It is. So let us begin with block 1, node-positive penile cancer.
All right, lay it on me.
Here's the initial presentation. A 60-year-old uncircumcised man is referred to your multidisciplinary tumor board.
Okay, 60 years old.
He noticed a painless glands lesion about 6 months ago that has been progressively growing. On examination, there's a 3.5-centimeter exophytic mass on the gland's penis.
Got it. 3.5 centimeters.
And a punch biopsy confirms moderately differentiated squamous cell carcinoma, or SCC.
Okay.
Now, on physical examination, you palpate a 2-centimeter mobile, non-tender lymph node in the right inguinal region. The left groin is clinically negative.
All right.
So how do you complete the workup and frame the key clinical decision points?
Let me organize my answer. I will break this down into the workup of the primary tumor, the cross-sectional staging, and then the specific evaluation of the nodal basin.
That sounds like a good structure. Go ahead.
So this is a biopsy-proven glans penile SCC with a clinically suspicious unilateral inguinal node. And, in penile cancer, the presence, extent, and bilaterality of nodal metastasis represent the dominant prognostic factors.
They absolutely do.
Right. So the key clinical decision point is establishing whether this palpable groin node is reactive and inflammatory or if it represents true metastatic disease.
That is the right framework. Detail the imaging and the physical interventions you need to answer that exact question.
Well, for the primary tumor, I want dedicated local staging with a penile MRI to assess the depth of invasion.
What are you looking for on the MRI specifically?
Specifically, I'm looking to see whether the lesion involves the corpus spongiosum or if it extends deeper into the corpora cavernosa. This anatomic distinction dictates the T stage.
Okay, and for the rest of the body?
For cross-sectional staging, I want a CT of the chest, abdomen, and pelvis with IV contrast. I need to evaluate for any occult pelvic adenopathy or distant visceral disease.
Makes sense. And the groin.
Finally, regarding that palpable groin node, I need tissue confirmation before committing to any therapeutic nodal treatment.
Tissue confirmation, okay.
Yeah, a mobile unilateral node in this setting should undergo a percutaneous FNA or a core needle biopsy under ultrasound guidance.
I'm going to push back there. You have a 3.5-centimeter primary mass and a 2-centimeter palpable node sitting directly in the primary drainage pathway.
Right. It's highly suspicious.
It is. So why mandate the needle biopsy? I mean, why wouldn't you just treat it based on palpation and move straight to an inguinal dissection?
On boards, I would say it this way. Clinical exam alone is notoriously unreliable in penile cancer.
Really? How unreliable?
Up to 50% of palpable nodes in this disease are actually falsely positive.
Why is that?
Because these primary tumors are often ulcerated, infected, or necrotic, especially in uncircumcised patients where, hygiene can be compromised under the prepuce. So a significant percentage of palpable inguinal nodes are purely reactive and inflammatory.
So what happens if you just dissect it?
If we commit to a morbid procedure like a therapeutic inguinal lymph node dissection based on palpation alone, we risk overtreating a reactive node.
Yeah, and what's the consequence of that?
We would be subjecting the patient to the lifelong morbidity of lymphedema, wound breakdown, and chronic infection for a completely benign node.
Right. But what if your needle misses?
That's the other side of it. We must also recognize the limits of the needle biopsy. If the FNA is negative but my clinical suspicion remains high, the groin cannot just be dismissed.
Good catch.
It still requires further pathologic evaluation, like a superficial modified inguinal dissection, because a false negative needle biopsy is a known risk.
Okay, well, what about doing an open excisional biopsy of that node in the clinic, just to be absolutely sure right then and there?
Oh, no. I would strongly advise against an open excisional biopsy of an inguinal node in this setting.
Why is that a bad idea?
Violating the groin lymphatics with an open biopsy can alter the lymphatic drainage patterns. It complicates future definitive surgical dissections, and it drastically increases the risk of regional skin seeding or just terrible wound complications. Needle biopsy is the standard first step.
That is a much safer answer. The most common error I see is residents eagerly rushing to the operating room without tissue.
It's a huge temptation.
It is. But in penile cancer, the groin is the prognosis. Do not base definitive nodal treatment on palpation alone when histologic confirmation via needle biopsy is feasible. You must prove it.
Got it. Always get tissue.
Right. Let us move to the staging and risk stratification. We obtain the imaging you requested.
Okay, what does it show?
The penile MRI shows a distinct low-signal tunica albuginea, indicating that while the tumor heavily invades the corpus spongiosum, there is no extension into the corpora cavernosa.
Okay, spongiosum only.
Correct. And the CT, the chest, abdomen, and pelvis, shows no distant metastases and no enlarged pelvic lymph nodes.
Good news there.
Yep. So, using the AJCC 8th edition, what is the clinical stage, and how exactly does that MRI finding drive your nodal management here?
Well, based on the imaging, invasion of the corpus spongiosum without cavernosal invasion makes this a T2 primary.
Correct.
And because he has a clinically suspicious unilateral mobile inguinal node, clinically this is CN1 pending the histologic confirmation we just discussed.
Walk me through the nodal logic. How does a T2 primary dictate your next steps?
The key decision point here relies on the oncologic concept of a high-risk primary.
Okay, explain that concept.
Penile cancer has a very predictable sequential pattern of lymphatic spread. It almost always travels to the superficial inguinal nodes first, then the deep inguinal nodes, and then finally the pelvic nodes. So any penile tumor that is T1b or higher, which the AJCC defines as having lymphovascular invasion, perineural invasion, or grade 3 histology, carries a significant risk of occult microscopic nodal metastasis, often exceeding 20%.
And this patient, how does he fit into that?
This patient is high risk strictly on the basis of having a T2 stage primary, meaning spongiosal invasion. Because it is a high-risk primary, significant occult nodal risk exists bilaterally.
Laterally, even with a one-sided node.
Yes. The lymphatic drainage of the penis can easily cross the midline at the base. This mandates bilateral inguinal evaluation.
So the physical exam doesn't change that?
Not at all. This is required regardless of what we feel on palpation. So even if the right node was negative on physical exam, this is absolutely not a surveillance-only groin case. We must address both groins pathologically or therapeutically.
Excellent. The trap here is tunnel vision.
Getting distracted by the palpable node.
Precisely. The most important distinction is not just node positive versus node negative. It is low risk versus high risk primary biology, because that biology determines how aggressive you must be about evaluating the contralateral, clinically negative groin.
Right, you can't ignore the left side just because you feel something on the right.
Exactly. Do not fall into the trap of focusing solely on the palpable node while ignoring the occult risk right next door.
Definitely won't.
Now, let us discuss the management of the primary lesion. He has a 3.5 centimeter T2 glands SCC. What treatment options do you discuss for the primary tumor, and what is your preferred recommendation?
I will lay out the two main definitive options: surgery and radiation.
Okay, start with surgery.
Surgery is the standard, traditional starting point. Depending on the exact local extent and the reconstructive options available at our center, this may mean organ-preserving glands-directed surgery, or more likely for a 3.5 centimeter lesion, a partial penectomy. The absolute operative goal is obtaining a negative margin.
How big of a margin do you need?
Historically, a 2-centimeter margin was taught, but modern guidelines support a margin as close as 5 millimeters, provided it is confirmed negative on intraoperative frozen section. This is to maximize the functional length of the penile stump.
And what about radiation? He asked you if he could just keep his anatomy intact.
Radiation-based preservation is a real, valid discussion point for selected patients. Radiotherapy, particularly interstitial brachytherapy, is a highly effective organ-preserving option for appropriately selected T1 to T2 lesions.
When is it best suited?
It is best suited when tumors are limited in size, typically under 4 centimeters, and when the patient accepts the need for very rigorous, close follow-up and potential salvage surgery if a local recurrence happens.
What are the specific prerequisites if you were to offer radiation? I mean, can you just treat him as he is?
No, absolutely not. If radiation is chosen, whether external beam or brachytherapy, I must explicitly state that a prophylactic circumcision should be performed first.
Why is that so important?
The prepuce must be removed. Irradiating an intact foreskin will lead to severe radiation-induced phimosis, catastrophic skin toxicity, trapped moisture leading to infection, and honestly, it will obscure our ability to visually examine the glands during post-treatment surveillance.
That sounds like a nightmare.
Yeah.
So you've laid out the options. Which do you recommend for this specific patient today?
In this specific case, my preferred recommendation is surgery for the primary.
Why not the organ-preserving radiation?
The presence of a clinically suspicious groin node severely complicates the sequencing. If we pursue prolonged radiation for the primary, which can involve weeks of treatment, followed by a lengthy period of acute desquamation and inflammation, it delays the definitive management of the groin.
That makes sense.
Yeah, we want to avoid using 2 competing curative intent modalities simultaneously. Delivering a partial penectomy combined with high-dose definitive radiation to the primary, and the nodal basins introduces intersecting, compounding acute toxicities.
So surgery is cleaner.
Exactly. Surgery for the primary simplifies the sequencing. It allows us to secure local control quickly and then comprehensively stage and treat the groins without overlapping fields of acute inflammation.
Very well reasoned. Penile-preserving radiation is highly effective in selected early lesions, but concurrent nodal complexity often pushes the multidisciplinary team towards surgery for the primary.
Just to keep things manageable.
Right. Keep your sequencing clean on the boards. If the groin is the prognosis, do not let an overly complex primary treatment plan delay addressing the nodes.
That's a great pearl.
Let us move to the post-surgical findings. The patient undergoes a partial penectomy, and the margins are negative.
Great.
A circumcision is performed at the time of surgery, and the right FNA you ordered returns positive for SCC.
Okay, so it was metastatic.
It was. Because of the high-risk T2 primary and the positive right node, a bilateral inguinal lymph node dissection is performed.
Right, what does the path show?
Here is the final pathology. The right side shows 2 of 8 inguinal nodes positive for metastatic SCC. Crucially, the pathologist notes extranodal extension in one of the right nodes.
Oh, okay.
The left side is 0 of 6. No pelvic lymph node dissection was performed at the time of surgery. I need your pathologic nodal stage, your stage group, and your recommended next steps.
Let me organize my answer, starting with the staging. I use a simple unbreakable memory aid for this exact scenario. E&E equals PN3.
I like that.
Because the pathologist identified extranodal extension on the right side, the nodal stage is automatically upgraded to PN3, regardless of the absolute number of positive nodes or the size of the nose.
And the overall staging.
In the AJCC staging system for penile cancer, any T-N3, M0 automatically designates this as stage IV disease.
So it is stage 5V. Should we be transitioning to palliative chemotherapy?
No, absolutely not.
Why not? Stage IV usually means palliative.
While a stage IV designation sounds ominous and often implies incurable distant disease and other malignancies, in this specific anatomic context, PN3, stage IV represents regionally confined locoregional disease.
Right. It hasn't spread to the lungs or liver.
Exactly. It is aggressive, but it is not distant metastatic disease. Therefore, my recommendation remains heavily focused on aggressive locoregional multimodality treatment. We do not default to palliation.
Good. Defend your next steps.
My immediate next step is to recommend an ipsilateral right pelvic lymph node dissection.
Why go back in for surgery?
The presence of extranodal extension in the inguinal basin, or having 3 or more positive inguinal nodes, is associated with a substantially higher risk of occult microscopic disease migrating up the chain into the pelvic nodal basins, specifically the external iliacs.
So you have to check the pelvis.
Since no pelvic dissection was done initially, it is indicated now to complete the staging and provide regional clearance.
Okay, suppose the pelvic dissection yields 0 of 5 nodes. What then? The surgeon says, cut it all out. The margins are negative. We're done.
I would gently push back and reference the high risk of regional failure with surgery alone in PN3 disease. Following the pelvic dissection, I would recommend adjuvant multimodality therapy rather than observation.
How would you phrase that on the boards?
On boards, I would say it this way. I recommend adjuvant inguinopelvic radiation with a strong consideration for concurrent chemosensitization and systemic therapy to be finalized in a multidisciplinary discussion.
What data supports that?
I would bring up the ongoing IMPACT-T trial as context here.
The IMPACT-T trial.
Yes, the IMPACT-T trial is specifically investigating the sequencing of surgery, chemotherapy, and chemoradiation in node-positive penile cancer.
What do we know right now, though?
While we await definitive mature data to dictate the absolute standard of care, we know that surgery alone for extranodal extension yields unacceptably high locoregional recurrence rates.
That's the key.
The standard of care for PN3 disease leans heavily on aggressive multimodality escalation, typically involving postoperative radiation to the bilateral groins and ipsilateral pelvis to sterilize microscopic residual disease.
I'm glad you brought up the IMPACT-T trial. It shows you understand the limits of our current evidence. The teaching point here is absolute. Extranodal extension in penile cancer equals PN3, and PN3 equals stage IV.
But stage IV doesn't mean palliation.
Exactly. But stage IV here means regionally confined disease needing multidisciplinary escalation. You must project confidence in pursuing a cure here.
Will do.
The multidisciplinary team agrees with your logic. The patient will receive adjuvant radiotherapy. Walk me through your simulation, your target volumes, your dose, and your organs at risk.
For simulation, I would position the patient supine. I prefer a frog leg position or gentle external rotation and abduction of the lower extremities, utilizing a vac lock bag for immobilization.
Why not just treat him with his legs straight? I mean, it is much easier to set up.
Treating with the legs straight in the anatomic position causes the skin folds of the groin to overlap and create deep creases.
And why is that a problem for radiation?
The frog leg position helps to pull the skin folds taut, opens the inguinal creases, and significantly improves daily setup reproducibility. This is critical when treating shallow targets like the superficial inguinal nodes, as skin folds can drastically alter the radiological depth from day to day, leading to hot spots or underdosing.
Understood. Continue with the simulation.
I would request IV contrast, provided his renal function is adequate. The femoral vessels, specifically the femoral artery and vein, are the absolute key contouring landmarks for defining the deep inguinal nodes.
Hard to see without contrast.
Very hard. Without contrast, distinguishing these vessels from adjacent muscle and undissected lymph nodes is challenging. Finally, I would instruct the patient to have a comfortably full bladder to displace the small bowel superiorly and out of the pelvic radiation field.
Do you treat the penile stump?
I do not need to treat the penile stump because the surgical margins were negative and there is no clinical concern for residual primary disease.
And your targets. Let us be specific.
My elective clinical target volume must include the bilateral superficial and deep inguinal basins. I must explicitly contour and include the prepubic fat space extending up toward the suspensory ligament of the penis.
Why that fat space?
This is a common rate of lymphatic transit that bridges the bilateral drainage pathways, and it is very easy to undercontour if you are just following standard pelvic node guidelines.
To the point.
I will also include the bilateral pelvic nodes, which encompasses the external iliac, obturator, and internal iliac chains, extending up to the common iliac bifurcation.
What doses are we using?
I would prescribe 45 to 50.4 gray in standard 1.8 gray daily fractionation to the elective bibasin inguinopelvic nodal volumes.
And the right groin.
Following that, I would deliver a sequential boost to the high-risk right groin post-operative bed, specifically targeting the area where the extranodal extension was found.
What dose for the boost?
This boost volume depends on the extent of the E&E and the surgical clips. Treating microscopic post-operative risk requires a different dose than treating gross residual disease. A typical boost might take the total dose to 60 to 66 gray, depending on the perceived risk of microscopic residual.
Let me push you on the physics of this setup. You are likely treating this with VMAT. What is the major technical pitfall when optimizing this plan, and how exactly do you prevent it?
The most critical technical pitfall with VMAT in this region is superficial target undercoverage.
Explain that.
The superficial inguinal nodes sit in the subcutaneous fat, often just millimeters beneath the dermis. Modern inverse planning algorithms are designed with cost functions that aggressively penalize high doses to the skin surface.
So what does the computer do?
If I plan this like a standard deep pelvic IMRT case and allow the optimizer to run without restriction, the algorithm will inadvertently carve the dose away from the superficial CTV to spare the skin.
So how do you fix it?
I would prevent this by utilizing one of two methods. I could place a physical bolus, such as a 0.5 centimeter tissue equivalent material, over the inguinal creases during treatment to physically pull the dose buildup region to the skin surface.
What?
But, however, this dramatically increases the risk of severe acute skin toxicity.
So what's the alternative?
Alternatively, and preferably, I would use explicit optimization constraints in the planning software. I can create a dummy structure encompassing the skin and superficial tissue overlying the target and force the optimizer to deliver the prescription dose to that structure, overriding its default skin-sparing programming.
That is a highly sophisticated answer.
Yeah.
If you do not deliberately protect superficial CTV coverage in the groin with explicit constraints, modern planning will happily create a beautiful miss.
And we definitely don't want that.
You will spare the skin perfectly, and the patient will fail exactly where the disease lives.
Right.
After treatment, what outcomes do you expect, and what specific quality of life issue must be heavily emphasized to the patient before we even turn on the machine?
Well, given the PN3 status and the extranodal extension, this represents very high-risk regional disease. I must counsel the patient that despite our aggressive approach, his prognosis remains guarded, with a significant risk of distant or regional failure.
And how do you follow him?
My surveillance strategy will focus intensely on physical exams of the groins and pelvis, along with cross-sectional imaging of the chest, abdomen, and pelvis every 3 to 6 months, particularly during the highest risk first 2 to 3 years after treatment.
And the quality of life counseling. What is the functional reality for this man?
The dominant, unavoidable, and often devastating long-term toxicity issue is lymphedema.
Why is it so severe here?
This patient has undergone both bilateral groin surgery, which severs the primary lymphatic trunks draining the lower extremities, and high-dose groin radiation, which induces fibrosis and destroys any remaining collateral lymphatic channels.
How do you explain that to the patient, and how do you manage it?
I explain that the fluid in his legs will have no efficient pathway back to his heart. This leads to a buildup of protein-rich fluid in the interstitial space, increasing tissue pressure and swelling.
Right.
I would counsel him explicitly about the near certainty of chronic lower extremity edema and potentially massive scrotal edema. We must discuss the severe risk of recurrent cellulitis because stagnant lymphatic fluid is a breeding ground for bacteria.
What's the intervention?
I would emphasize the absolute need for daily compression garments to mechanically force the fluid upward, and I would place an early referral to a dedicated lymphedema physical therapy specialist right now.
Before symptoms start.
Yes, before symptoms even begin, to establish a baseline and educate him on manual lymphatic drainage. Furthermore, I would counsel him on acute toxicities like severe moist desquamation in the inguinal folds, as well as the profound body image and sexual function changes resulting from a combined partial penectomy and nodal irradiation.
You cannot gloss over the side effects on the oral boards. For combined groin surgery plus groin radiation, lymphedema is not a side note. It is a central survivorship issue.
It really defines their quality of life.
It does. You must prove to the board that you take it seriously and that you manage it proactively, not reactively.
Makes complete sense.
Let us change the scenario for a Block 1 subcase twist. Same patient. It is the same primary tumor, a 3.5 centimeter T2 glans SCC.
Okay.
However, he presents to your clinic initially with a 5 centimeter fixed immovable right inguinal mass, bilateral palpable groin nodes, and a highly suspicious 3 centimeter right external iliac node seen on the CT scan.
Oh, wow. Okay.
An FNA of the fixed inguinal mass is positive for SCC. How does your management change?
This clinical presentation completely shifts the treatment paradigm. We are no longer discussing a surgery-first approach for the nodes.
Why is that?
The presence of bulky fixed inguinal disease and radiographically suspicious pelvic nodal disease moves the sequence firmly toward neoadjuvant systemic therapy.
Why not just take him to the operating room and resect the primary and the nodes right now? The surgeon says he can get it out.
Attempting upfront surgery on a 5 centimeter fixed inguinal mass carries an unacceptably high risk of catastrophic morbidity.
What does fixed actually mean anatomically?
Fixed implies invasion into the underlying fascia, musculature, or the femoral vessels themselves. If the surgeon attempts an upfront resection, there is an extremely high risk of leaving gross positive margins.
And functionally?
More dangerously, dissecting a fixed mass off the femoral artery and vein in a field that will likely suffer poor womb healing sets the stage for a catastrophic femoral vessel blowout, which is a lethal complication.
Right. And the pelvic node.
Furthermore, the presence of a 3 centimeter external iliac node suggests the disease is rapidly migrating systemically.
So what systemic therapy are you recommending and why?
I would recommend neoadjuvant multi-agent chemotherapy. The standard aggressive regimen here is a cisplatin and taxane-based combination, such as TIP,
TIPB.
paclitaxel, ifosfamide, and cisplatin, assuming he has adequate renal function and performance status to tolerate it. We use this regimen because penile SCC is chemosensitive, and our goal is to site reduce this massive burden to make a subsequent surgery safe and margin negative.
What if his creatinine clearance is 35 milliliters per minute?
If his creatinine clearance is 45, he is generally considered cisplatin ineligible, as cisplatin requires robust renal clearance to avoid severe nephrotoxicity.
So what's your backup?
In that scenario, I would discuss a carboplatin-based alternative, though the efficacy is slightly less robust, or I would move toward definitive concurrent chemoradiation as our primary locoregional strategy, recognizing that we lose the cytoreductive surgical option.
Assuming he gets the TIP and tolerates it, what happens next?
After a formal radiologic and clinical response assessment, if the nodal mass shrinks, detaches from the underlying structures, and becomes mobile and surgically resectable, I would pursue consolidative surgery, a radical inguinal and pelvic lymph node dissection.
And if it doesn't shrink?
If the mass remains unresectable or fixed after systemic therapy, then definitive radiation therapy with concurrent chemosensitization becomes our only potential curative locoregional strategy.
Excellent pivot. Mobile unilateral small volume nodal disease and bulky fixed bilateral disease are completely different diseases from a sequencing standpoint.
You have to respect the fixed mass.
You do. Do not answer them the same way on the exam. Fixed means neoadjuvant therapy.
Got it.
That concludes Block 1. We will now move to Block 2. Locally advanced male urethral SCC, focusing on organ preservation logic.
Okay, shifting gears.
We have seen how penile cancer aggressively exploits the superficial inguinal pathways. The groin is the battleground. Now, I want to see if your nodal logic holds up when the anatomy shifts deeper.
I'm ready.
Here's the initial presentation. A 58-year-old man presents to the urologist with 6 months of progressive obstructive voiding symptoms, a weak stream, and 2 episodes of gross hematuria.
Okay, classic obstructive symptoms.
He was initially diagnosed with a benign urethral stricture, but prior dilation treatments for that stricture failed to improve his symptoms. A cystourethoroscopy is finally performed, revealing a 3-centimeter friable bleeding mass located precisely in the bulbar urethra.
Bulbar urethra, okay.
A transurethral biopsy is taken, which confirms moderately differentiated squamous cell carcinoma. How do you complete the workup and frame the key decisions?
Let me organize my answer by starting with the anatomic framework, because in urethral cancer, the specific anatomic location of the primary tumor dictates both the lymphatic drainage pathways and our treatment planning.
Okay, lay out the anatomy.
On boards, I like to conceptualize the bulbar urethra as a continental divide or watershed area for lymphatic drainage.
I like that analogy. Explain how the water flows.
The anterior urethra, the penile and medial portions, generally drains outward to the superficial and deep inguinal nodes, and then secondarily inward to the pelvic nodes.
And the posterior?
The posterior urethra, the membranous and prostatic portions, drains directly inward to the pelvic nodes, primarily the obturator and internal iliacs, bypassing the groins entirely.
So where does the bulbar urethra fit?
The bulbar urethra sits right on the ridge of this divide. This means its lymphatic drainage flows both ways simultaneously, outward to the bilateral inguinal basins and inward to the bilateral pelvic basins.
Good anatomical foundation. How does that watershed concept dictate your workup for this specific patient?
For local staging, I require a dedicated pelvic MRI to define the exact local extent of the 3-centimeter mass.
What exactly are you looking for in the MRI here?
I specifically need to assess for periurethral soft tissue extension, spongiosal involvement, or deeper corporal invasion into the adjacent erectile tissues or the urogenital diaphragm. MRI is vastly superior to CT for resolving this soft tissue contrast.
In distant staging?
For distant staging, I need a CT of the chest, abdomen, and pelvis with contrast.
What if you feel a 1-centimeter node in his left groin?
If I identify any enlarged nodes on exam or imaging, I must evaluate them directly with an ultrasound-guided FNA.
Why? Is it the same as penile cancer?
No, this is a critical distinction from penile cancer.
Yeah.
An enlarged node in the setting of urethral cancer has a much higher likelihood of harboring true metastasis than being a purely reactive inflammatory node.
Okay, so what are the decision points?
The key clinical decision points moving forward will be determining the precise local T stage based on the MRI, confirming the nodal status, and then deciding whether the patient is best served by extirpative radical surgery or a preservation-first chemoradiation approach.
Very solid reasoning. For bulbar urethral tumors, anatomy matters twice. Once for T-stage depth and once for determining the nodal drainage pathway. You must know exactly where the tumor sits on that continuum.
Right, it drives everything.
Let us move to the staging and treatment framework. The MRI is completed and shows periurethral soft tissue extension, but there is no deeper cavernosal, prostate, or bladder neck invasion. The cross-sectional CT is negative for distant visceral disease. However, there are bilateral 8 mm inguinal nodes seen on the CT. They are deemed indeterminate on standard imaging, but a subsequent PET scan shows they are not FDG avid.
Or a negative PET.
What is your stage, and what options do you present at the tumor board?
Based on the AJCC staging system for urethral carcinoma, invasion of the periurethral muscle or the corpus spongiosum without deeper cavernosal invasion classifies this as a T2 primary.
And the nodes.
Because the 8 mm nodes are indeterminate but definitively PET negative and there is no distant disease, I will stage this as clinically T2 N0N0.
What are the treatment options you present to the patient? He is healthy, 58 years old, and works full-time.
I will present two major definitive curative intent pathways. The first option is extirpative surgery, which would involve a radical urethrectomy and potentially a more extensive resection, such as a partial or total penectomy, depending on what the urologist requires to achieve clear negative margins.
That's a huge operation. What's the alternative?
The second option, which I would heavily highlight for a T2 bulbar lesion, is definitive concurrent chemoradiation.
Let me stop you. Often residents present radiation for urethral cancer as a fallback for frail, elderly patients who are too sick for a long surgery. Are you offering this as a palliative backup because you don't think he can handle the operation?
Absolutely not. For locally advanced SCC of the urethra, definitive chemoradiation is a primary curative option, not a compromise.
Tell me more.
I am presenting it deliberately as a pathway to preserve the male anatomy and avoid a permanent perineal uretherostomy or amputation without sacrificing the opportunity for an oncologic cure. The choice between the two pathways will depend on the expected surgical morbidity, the patient's personal priorities regarding genital preservation, and our institutional expertise. But chemoradiation is a Tier 1 option here.
Perfect. Do not hedge on this. For locally advanced urethral SCC, definitive chemoradiation is a real curative option supported by the guidelines. Your script on the oral boards should sound deliberate, not apologetic.
Curative intent organ preservation.
Exactly. The patient hears the options and strongly desires organ preservation. He wants to avoid radical extirpative surgery at all costs. Walk me through your definitive chemoradiation plan. Start with the setup.
The key decision point here is managing that watershed drainage. I will simulate the patient supine using a highly reproducible perineal setup.
Like what?
I typically use a frog leg position with a vac lock to expose the perineum and groins. I will explicitly request that a Foley catheter be placed by urology or nursing prior to the simulation scan to help clearly define the urethral course and the exact location of the primary tumor on my planning CT.
Do you need any other imaging?
Yes. Furthermore, MRI fusion is absolutely mandatory here because a non-contrast CT alone will drastically underestimate the true extent of that periurethral soft tissue extension we identified earlier.
What are your target volumes? Use your earlier analogy.
Because the bulbar urethra sits on that watershed ridge, my mnemonic delivery for the boards is bulbar is bibasin.
Bibasin, meaning?
This means my elective clinical target volume must cover both the bilateral inguinal nodal basins and the bilateral pelvic nodal basins. I cannot just treat the pelvis and ignore the groins, or vice versa.
And the primary.
I will also target the gross primary tumor, the involved segment of the bulbar urethra with a margin, the adjacent periurethral tissues, and the perineal body.
Walk me through the dose and the systemic therapy. How are we achieving the cure?
I will prescribe 45 to 50 gray in standard 1.8 gray fractions to my elective bibasin nodal volumes and the subclinical primary margins.
Then a boost.
I will then boost the gross primary disease to a definitive total dose in the mid-60s to 70 gray. I will modulate that final boost number based on the patient's specific anatomy and the adjacent normal tissue constraints, specifically respecting the rectal and anal canal tolerance.
And the chemotherapy.
Because this is a squamous cell carcinoma, a radiosensitizing backbone is strictly required. We borrow heavily from the anal cancer paradigm here. I would recommend concurrent 5-FU plus mitomycin C.
Why mitomycin? It is an old drug. Why not just use cisplatin?
Mitomycin C is uniquely effective in this setting because it acts as a hypoxic cytotoxin.
How does that help with radiation?
Squamous cell carcinomas in these regions often outgrow their blood supply, creating hypoxic cores that are inherently resistant to radiation, since radiation relies on oxygen-free radicals to damage DNA.
So mitomycin works in that environment.
Exactly. Mitomycin preferentially alkylates DNA in these low-oxygen environments, synergizing perfectly with the radiation. While cisplatin-based alternatives are also acceptable depending on patient fitness and medical oncology preference, the 5-FU and mitomycin combination is the classic, highly efficacious radiosensitizing regimen for pelvic SCC.
Excellent mechanistic explanation. Would you utilize a brachytherapy boost for that gross primary disease in the urethra to get the dose higher?
I would only incorporate an interstitial brachytherapy boost if my specific center possesses high-volume, demonstrable expertise in urethral brachytherapy.
It's not standard everywhere.
No, it is a highly specialized procedure requiring precise template placement in the perineum. If that localized expertise does not exist in my department, pushing for brachytherapy introduces unnecessary risk of severe stricture, fistula, or geographic miss.
What's the alternative then?
EBRT alone, utilizing modern IMRT or VMAT to a definitive dose of 65 to 70 gray, is fully acceptable and defensible on the boards.
That is exactly right. Do not invent a capability your center doesn't have just because it sounds fancy to the examiner. In rare site radiation, do not force a brachytherapy answer if you cannot safely execute it. EBRT alone to a definitive dose is fully acceptable.
Keep it safe and standard.
He completes the chemoradiation treatment without any prolonged breaks. How do you assess his response? And more importantly, how do you counsel him moving forward regarding his long-term survivorship?
I will schedule his first formal response assessment at 8 to 12 weeks post-treatment. I will not assess him at 4 weeks.
Why not 4 weeks? You want to know if it worked, right?
Because at 4 weeks, the acute radiation inflammation, edema, and mucosal sloughing are still peaking. It is impossible to distinguish residual tumor from radiation effect, and a biopsy at that time would likely yield necrotic debris and increase the risk of a non-healing ulcer.
So you wait.
Waiting 8 to 12 weeks allows the acute inflammation to subside and the full therapeutic effect of the radiation and mitotic cell death to mature.
What does the assessment entail?
The assessment will include a physical exam, a cystoarthroscopy performed by urology, repeat pelvic MRI imaging, and a biopsy only if there is a highly clinically suspicious focal residual lesion.
What are the pathways based on that 12-week assessment?
If he demonstrates a complete clinical and radiographic response, he enters a rigorous surveillance program. If there is persistent biopsy-proven invasive disease, our multidisciplinary discussion immediately shifts to salvage radical surgery.
And what must you heavily emphasize in your counseling regarding his survivorship? You saved his urethra, he is cured. Is his life back to normal?
Well, I must be incredibly direct and honest about the difference between anatomic preservation and functional preservation. I successfully preserved his organ anatomically, but I must counsel him that late toxicities from 70 gray to the perineum are severe and often progressive.
Like what?
He is at a very high risk for developing a severe, dense urethral stricture that may require repeated dilations. He is at high risk for profound voiding dysfunction, incontinence, and severe erectile dysfunction due to radiation damage to the neurovascular bundles and corporal fibrosis.
And that's a lot.
Yes. Furthermore, he is at risk for catastrophic complications like a urethral fistula or soft tissue necrosis. Finally, because we electively irradiated both groins, he faces the exact same long-term lymphedema risks we discussed in the penile case.
Very tough conversation.
These risks must be stated clearly up front so he understands that preserving the anatomy does not guarantee preserving normal function.
Very good. You must manage expectations. The best preservation answer is honest about function. Do not sell anatomy preservation as normal function preservation, or the patient will feel betrayed when the strictures start forming.
Transparency is key.
We have a Block 2 subcase twist. It is a different patient entirely. A 65-year-old man presents with gross hematuria.
Okay, new patient.
A cystoscopy is performed, and a mass is found arising entirely from the prostatic urethra. The urologist performs a transurethral resection, which shows high-grade urothelial carcinoma, not squamous cell.
Prostatic urethra, urothelial.
Okay. More importantly, the pathology report notes stromal invasion into the prostate. The pelvic MRI confirms prostatic stromal invasion, and the CT is negative for nodes or distant spread. How does the specific histology and location change your answer?
This completely changes the treatment paradigm from top to bottom. First, regarding staging. In prostatic urethral urothelial carcinoma, the presence of stromal invasion automatically classifies this as a T2
And the
lesion.
treatment?
Second, because of the urothelial histology and the posterior location, the treatment logic entirely defaults to a bladder cancer framework.
Walk me through that framework.
Because this is an invasive urothelial carcinoma of the prostatic urethra, the standard board-defensible reference answer is extirpative surgery. Specifically, I would recommend a radical cystoprostatectomy with a bilateral pelvic lymph node dissection.
And systemic therapy.
Furthermore, borrowing from the bladder cancer data, this surgery should be preceded by neoadjuvant cisplatin-based systemic therapy, assuming he is cisplatin eligible.
What about organ preservation with radiation? You just gave a beautiful defense of chemoradiation for the bulbar squamous cell patient. Why not this guy?
The biology and the anatomy are fundamentally different. Nodal drainage here is strictly pelvic only, so the inguinal basins are out of the picture. More importantly, radiation-based organ preservation is much less established for invasive urothelial carcinoma of the prostatic urethra compared to squamous cell carcinoma of the anterior or bulbar urethra.
But doesn't trimodality therapy exist for bladder cancer?
While trimodality therapy exists for bladder cancer, applying it to a primary prostatic urethral urothelial tumor with stromal invasion carries a very high risk of local failure and severe toxicity to the bladder neck and sphincter.
So what do you tell the examiner?
If I am pushed on it by a patient who absolutely refuses surgery, I will acknowledge it exists in highly selected cases, but I must clearly state to the board that it is not the standard core answer here. Extirpation is the standard.
Excellent distinction. The teaching point is that histology and location both matter simultaneously. Bulbar SCC is where preservation-first chemoradiation is most defensible. Prostatic urothelial carcinoma with stromal invasion is where extirpative surgery becomes the standard board answer.
Got it. Treat it like bladder cancer.
You have done well. We will now conclude with a rapid-fire board review. I will fire off 3 quick questions. I want you to answer concisely based on AJCC criteria and established guidelines. Question 1. A 62-year-old man undergoes a bilateral inguinal dissection for penile SCC. Final pathology reveals 3 of 7 right inguinal nodes are positive without any extranodal extension. The left side is 0 of 6. What is the precise pathologic end stage?
PN2. The presence of 3 or more unilateral nodes without extranodal extension defines PN2.
Question 2. You are planning definitive chemoradiation for a T2 bulbar urethral SCC. Which specific nodal basins do you electively cover in your CTV?
Both the bilateral inguinal and bilateral pelvic nodal basins, due to the watershed bidirectional drainage pattern of the bulbar urethra.
Question 3. A 63-year-old man with a 2.5 centimeter T1B grade 3 Lanz SCC is being considered for definitive radiation therapy. Is grade 3 histology an absolute contraindication to an organ preservation approach?
No. Grade alone is not an absolute contraindication to radiation. The decision relies heavily on the lesion's extent, depth of invasion, and the local institutional expertise. However close, rigorous surveillance is mandatory due to a higher baseline risk of local failure with grade 3 disease.
That concludes our mock oral board session on penile and urethral cancer. Let me concisely recap the main board-ready takeaways. First, master penile nodal staging. Remember that extranodal extension equals an automatic upgrade to PN3, which is stage IV. But it requires aggressive multimodality curative treatment, not palliation.
Stage 5E isn't always metastatic.
Exactly. Second, understand the sequencing for fixed versus mobile nodes. Mobile unilateral nodes go to upfront surgery or biopsy, while bulky, fixed nodes demand neoadjuvant chemotherapy like TIP to prevent catastrophic surgical morbidity.
Mobile gets surgery, fixed gets chemo.
Third, understand the bulbar watershed drainage logic, which requires bi-basin elective coverage for both the inguinal and pelvic regions.
Bulbar is bi-basin.
Finally, recognize the critical difference between SCC preservation pathways in the bulbar urethra versus the urothelial extirpation logic required for the prostatic urethra. Complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.